At the outset, let me put it straight on the record. My tryst with inner ear started when we started doing the cochlear implant program about 13 years ago. And it was through cochleostomy you got to read a little bit into the anatomy and the physiological aspects, but never the vestibule till I did the first labyrinthectomy and the vestibular nerve section. But having known this, we in our department had some special interest. Just yesterday you would have heard Dr. Ashwini talking about, she's from my department, and she had a special interest in this. However, that was for the last 5 years or so. But after I got initiated into this, it was like the curiosity killed the cat. So I have to place on record Dr. Ravi Nair and Srinivas to enthuse me into the world of Cyclops, which we knew only was an endoscopic equipment a few years ago. But there's so much to learn. I'm just a toddler, probably an infantile presentation. We focus on the outcomes, and this is a small bit of my experience in the last 11 months that we have had this. The same patient, a few patient profile that I'm going to talk about. We are taking a study, and pre and post operatively, we have been using this Cyclops to good effect. So, welcome criticisms, constructive or otherwise, but this is how we've gone about. Now, my objectives of this talk is very simple. We just would go about just an introduction. He's already introduced in the last 2 days. A lot of speakers, very enthralled presentations. We were all there as an audience and we learned a lot. To understand a bit of the concept, the clinical application that we have in our system, in our teaching hospital, and outcomes of a pilot study we have undertaken, and future trends. This is how I'm going to go about. To talk about ENG, we know eye is the most important part. Like yesterday, we knew the function of the semicircular canal is fixation of vision, which we always thought about as a part which is the domain of the ophthalmologist. So in most, why do we do this? Because many balance disorders, which are like the one talk in the morning, one attack, we all have had similar attacks. Maybe yesterday, after yesterday's little ataxic gait, people might have had a little bit of the quasi-vertiginous attacks. But when they come back to you, you know you're lost. So that's why I said most of the neurological and ENT examinations, they've just pitched back and forth, and you really don't get to know where you are. This balance mechanism, which can be documented, has given a way forward. Well, this I'm not going to go into it. Vestibular ocular reflex, which was just discussed a couple of minutes back. But I've got a few points to talk about here. This is more of a teaching part for the youngsters. Well, we are all learning in the same platform. Talking about it stabilizes the eye position within a range of 50 degrees. There is some objectivity to it, 50 degrees. And that's how you can just message your own colleagues, as if this is a little abnormal, let's go forward. And is to prevent retinal slip by coordinated action, which was illustrated very nicely by my previous speaker. And also, head impulse tests, head shake. These are all the tests that would be incorporated into the system. Now, everybody talks about different vestibular systems. Why VNG and not ENG? Points are very clearly mentioned, and we all know that. We've had this in the past, and we see it's definitely less time consuming. You can finish it. If you really want to finish it, you can finish it within 15 minutes. Direct evaluation of the ocular motility, you can see. Recording is there for archived, for you can get into a teaching mode. And the advantage of recording torsional movement, which was not there earlier. That is an important part. And otolith function, obviously with this subjective visual vertical, you can just get to know at the same time the otolith function as well. Now, what are the goals of VNG? You need all the other tastings that comes out on its own after you have programmed it. We also have the direction, amplitude, frequency. of the entire system, oculomotor tract, and finally with the existing software, which is already updated 3 times in the last 1 year. With the kind connivance and the troubleshooters of Cyclops, I have to take place on record. They were very, very good. Whenever we wanted any change, they came and did it. Physiology, I'm not going to go. This is just for a completion. This is an important one. Now, what are the types, what are the different tests that you're trying to assess? Well, the teacher in me comes out in a medical college, so you have to ask the students, what are the vestibular organs and what are you testing actually? Now, you'll see some different colors. This is the entire gamut of the list, the entire, the domains of the vestibular system that you check out. But these are the 4 which interests us. I'm talking about the real hardcore surgeons. If you want to dabble with the inner ear, these are not a part and parcel of your research methodology. It's about these. And central pathway, all these are also assessed simultaneously. Well, this is nothing much. Before we embark on any, measurement values, this is important. You have to calibrate. And any cervical pathology, if it is associated straight away, this patient is out, we don't do it because ultimately we're going to create more harm than what would be good for our study. Now, how do we go about this? Is again a repetition, but I made it simple for the juniors to understand what is a saccade. To keep images of objects and prevent a retinal slip. That's it. And you've seen enough of it, so I'm not going to play this, just to save a little extra seconds for the next speakers. But this is just about it. This is a similar thing. It's just a prototype. You have a very good graphic representation which comes tracings along with it. And here, we always keep it for future references. This is a slow saccade. The same tracing, you see a little horizontal plane in between. I've understood it, understanding it, probably much, much more to understand in future. Fast saccades, this is just taken from the net. Intranuclear ophthalmoplegia. And you see how it happens. You can see the different torsional component. If the amplitude is 30 degree or more, you will find, you can imagine this, and exactly both of them have been represented in the same slide. And this is a tracing, actual tracing done. We didn't have a patient of such. Just wanted to complete the whole thing. Now, what are the parameters of the saccades that you tend to assess? They are latency, velocity, and all that we know that amplitude is based on the slow phase of nystagmus. Smooth pursuit, again, these are the important part. The ability of an image of an object which slowly goes through. It's a very smooth. If you just tend to sway from one to the other, that becomes a smooth pursuit. And here, you would see, ask the patient to look at a target. We have to upload all this in our armamentarium, but you see, it's a very smooth pursuit. This is all the basics, what we tend to know, we need to know before we get going with any sort of study that we want to do. This is exactly what is smooth pursuit. Very gentle, nice, and easy. Abnormal, we have just seen a graph in the case presentation a couple of hours ago. We see such kind of deviated spectrum which we do not know exactly where they are going. And abnormal smooth pursuit can happen in all these, anything. I really didn't understand this part in attention, but probably lack of focus is what they were meaning. So we had saccades, we had smooth pursuit, now we had optokinetic nystagmus, which again is a mention of to keep multiple moving objects. In smooth pursuit, it's a single object. In optokinetic, it's multiple. And you can see if they're able to do that, that you know the central functions are perfectly right. The last part of it, which interests all of us, is the otolith organs. And a combination of these otolith organs is, and the vertical canals, both together can cause and have an effect of what we call the subjective visual vertical, SVV. And this also is important. You can see that, same angulation to perceive how the angle of deviation can happen if there is an anomaly of the otolith function. Now, as such, what we have done is VNG. Why VNG? In the recordings of ENG, I'm talking about ENG, the spontaneous nystagmus, which is there between 5 or 10 degrees per second, they could be normal. But when you video record it and get the tracings done, you can find some anomaly. And as I told you, the slow phase and amplitude correlate. And if it is beyond 10 degrees per second, you know a patient is going to have a subtle sense of rotatory vertigo. Visual fixation in horizontal gaze nystagmus will differentiate unilateral from a from a central cause. Now coming to our pilot study. This was the initial preamble to which we started off this entire thing. I've entrusted one postgraduate to do this. And I thought, how am I going to be benefited? Other than meeting the norms and the requirement of the MCI or whatever, that you need to have something to test the vestibular system. Decided, luckily in our lab, I thought of stapedotomy. Why not? Because that is here we dabble with inadvertently or genuinely. There could be some problems associated with the membranous labyrinth that we do. And this is how we have done in the last, we are lucky, I was really lucky to have so many patients at the same time. So 27 patients of only stapedial, not even a minimal cochlear component in it, was done. And all the cases I've done endoscopically. I was doing earlier with microscope, but it's okay. And the fluoroplastic, similar, it was standardized with the fluoroplastic Grace Medical Preston, 0.5 thickness, and the length varied from 4.25 to 4.75. All the central causes of vertigo pre-operatively were completely dissociated. Only then they were part of the study. And VNG findings, 24 hours pre-op, because that's the time they come to the hospital for admission. And why 48 hours post-op was, the post-operatively, we would also give the labyrinth to take that amount of recoil or the rest or whatever you call it to get into normal physiological mode. So this, and surprise, all of us inverted, when we put the piston in, we are sure everything is fine. The patient has had a good improvement in hearing. We forget this, the nystagmus happens for some patients. We do not know what's going to happen. And I've gone through an archiving of literature search. There's no study till now anywhere. With ENG, there was a pilot study, but that was also far and few between. Now, what are the probable postulates as to why this can happen? This, they have shown why vertigo happens. It could be pressure changes by the piston, by the surgeon, by the patient, whatever. And there's a subtle subclinical inflammatory reaction that happens in the membranous labyrinth. There is reduced vascularity sometimes, an enzymatic process have been implicated, malposition, inappropriate length of piston, you know all that. But ultimately, I feel the perilymphatic pressure due to excessive straining by the patient and the inappropriate length and the placement. Some could be anterior, some could be posterior. Of course, all of these were done on the posterior part of the foot plate. Now, as I showed the slide earlier, the second slide again, just to tell you, only these 4 are of importance for us, post-operatively. We do the central pathway, that is important. That is already, by default, it is already taken into account. But spontaneous gaze, positional, and the subjective visual vertical are the ones we can look into. The parameter studies were the latency, duration, amplitude, similar things which has been standardized. Now, what did we observe? We thought we are doing excellent work. Yes, patient had improvement in hearing, but 3 patients out of 27, the last one was day before yesterday, had complaints of giddiness, persistent beyond 48 hours. And they were subjected to these VNG testing. Of course, 4 out of the rest 24 had only tinnitus, which really got back to normalcy. All the 3 patients benefited from stapedotomy with hearing improvement. But vertigo was an added, you can say, added association after the surgery was done. Now, why does this vertiginous crisis happen? Again, it's a postulate, but we should know. Could be rupture, micro rupture of the membranous labyrinth somewhere. And the mobile ossicles we keep testing and all that, that could be another learning part for the surgeon to be a little more deft and subtle and very, very fine with their movements. These were just the recordings, just for comparison, before and after. We do a preoperative central, preoperative peripheral, post-operative again central. And why, people would say, why central? Let us see whether the connections between the periphery and such a complicated audiovestibular system, so we do not know whether post-operatively if there's a change in the central as well. And again, post-operative, there's some changes, which I'm not going to discuss here. This was a patient done day before yesterday, and I hope it runs. This is how the patient had immediate post-operative. You can see the saccades. It's a little distortion with the images. Probably before it was in a hurry, I just did it and got back here. This is spontaneous nystagmus, same patient. You just see how in dark, and this is in light. This distorted images, those little bit artifacts that you see, probably will have to do some troubleshooting with the screen maybe. Oh, probably, probably. No, but the amplitude is the same of the patient. That is not changed. Okay. And I want you to see this part. Smooth pursuit is not smooth. I'll just, can you see this distortion a little bit? Anyway, we can, now going back to what I said in the beginning, what are the clinical applications when the response to either VRT or the drug therapy is questionable? And there are presence of complications, if you think. For a pre-surgical evaluation, we have something written, documented, objectified. So there is something to compare post-op, whether for the surgeon or for the patient or for the institution or for the medical record section, somewhere. And you also can evaluate a healthy labyrinth, how good it is during the process of a follow-up or any of the monitoring of any of the therapy or anything that you're trying to embark on or trying to do a retinal research. So the take-home message would be, VNG is here to stay. It gives a very good understanding of the vestibular physiology, which were neglected for a long time. But in our pilot study, efficacy of stapes surgery has never been studied post-operatively by vestibular objectives. Now we can do that, and probably it is a small number, only 27. Probably it'll be an ongoing study. Maybe if you have something like 100 in the next 3-4 years, this will be a very good insight into what you should be doing pre-op to prevent such things. Even how does it help the surgeon? We detect very early development of certain problems which can be mitigated by very quick recourse to some therapeutic measures. And of course, it's a good research tool. Thank you for a patient hearing. Any questions or comments?
Congratulations for a very good presentation and study of the stapes surgery patients. It reminds me of a study which is going on in AFMC Pune. Brigadier Renu Madam, she is doing this study. There are 2 groups of the patients. One is a routine stapedotomy and another is a laser stapedotomy. And they are doing vestibulostabilometry. a good, large group they have got now. But I really congratulate you, a very good topic. Thank you.
Just would like to add to what you said. I was doing laser stapedotomy right from 2003 onwards. And after doing 35, and we had a comparative study which was published also in the American Journal, realized that the conventional is here to stay. So I don't know, maybe a new insight into a particular type. Of course, we had KTP laser. Maybe they're doing with CO2, I guess.
They have got CO2 laser.
Probably that is a little better.
Thank you for your interesting presentation. Just little comment regarding the abnormal smooth pursuit you presented after stapedectomy surgery. This is, I think, it was because of the presence of a spontaneous nystagmus. You showed in your slide that there was a spontaneous nystagmus in dark and light. Just for the audience to know, spontaneous nystagmus can show up in the smooth pursuit, especially when the target is going towards the first phase of nystagmus. So the distortion was not because of central causes. There is no logic behind this, but most probably was because of the presence of spontaneous nystagmus.
I said distortion of the audio visual, not vestibular, because of the software.
You mentioned that the smooth pursuit was somewhat abnormal. That's why you went. Yeah. Thank you.